Good morning, Liviu. How are you?
Good morning. Thank you very much. How are
Is
you?
it, is it morning? I don't know. It is.
Yeah, it
So,
still is.
still is. I want to introduce Dr. Liviu Steyer. I've known Liviu for 23 years, right? Something along those
Yes.
lines.
Yeah.
So just to look at his bona fides, which are through the roof, he's been an assistant professor, course director, adjunct, whatever, masters of science directors at Warwick, Manchester, Edinburgh, Tufts, UPenn, and Florence, right? Did I miss anything?
And now India and Brazil.
Okay, so what do you do in your spare time?
I have my grandchildren, which I love.
That's the way to fly. Okay, so the point of this conversation today, other than it's a chance to catch up, is you have been involved and have patents now on one of the most intriguing areas of dentistry, biophotonics.
Yes.
It's the fellow here in Toronto that's doing that is I know Keishan, who's an endodontist.
Yes.
Who's been looking at that diagnostically and to treat it with nanoparticles. You, on the other hand, are focused on theragnosis. All right.
Yes.
So theragnosis is the ability to use fluorescence in various ways to come up with pathologic diagnosis, correct?
I would put it like this: therapy and diagnosis. So you start with diagnosis, are able to guide your treatment and understand if the treatment, the moment the treatment has been successfully completed.
Okay, but there are various types of fluorescence, and what are they?
Well, imagine you have chemiluminescence, you have bioluminescence, and you have autofluorescence. So the question is, who is the excited part which emits back the light?
Okay.
We deal here mostly with the body. Blood, when it is generated in the process of HEM, you will have so-called protoporphyrin generation. Okay. This is what you clearly can see using fluorescence. Pathogenic bacteria, mutants, Porphyromonas gingivalis and Actinomycetum comitans generate as well porphyrins. Putting fluorescence on, you can clearly see them, you see their presence, and you understand where you are.
So what you did was you looked at sort of existing science that was in place that had been used for tumors and the like, cranial tumors, other areas, but I know you pointed out cranial a lot of the time in your papers. So you adapted this now to dentistry. So what we're going to show today is kind of from the simple to the complex. So cardiology, prevention, ortho, and implants and fractures, detection of fractures. So that alone is justification for using this technology, because it will allow you to see things that X-rays, artificial intelligence, and all the rest don't. It's I don't know how to explain it. Well, you'll see when we're doing it, but what fascinated me when I saw the latest generation of Reveal in New York at the meeting was it's like this little thing. It's like just sits on the, instead of the light that normally clips onto Designs for Vision, they were vertical, but there was also, they're horizontal. Just like two lights, all right? Doesn't weigh anything, and it's easy as pie to use. Okay, so let's share your screen. I think I allowed you to do that.
Yes.
And we're going to walk everybody through while this plays. Bingo. Okay, so the only problem I have with this is you're not using Keynote, but that's okay. That's okay.
Okay, so let's start here.
Okay.
This is a daylight picture, and this is what you can see under fluorescence. You clearly see the crack here, and you clearly see under fluorescence the crack in red, meaning the crack is also infected. This is what you cannot see here, but you can clearly see it here. or you can see it here. Again, the crack and the crack infection. The redness proves there is bacteria in the crack. Okay, does it mean now you have to open up the crack? No, but you have to disinfect the crack. This is not the topic of today's meeting.
No, but the thing that impresses me the most here is that, I mean, this is basic karyology, understood, and this is essential. I mean, it just makes sense, right? You're not going to remove a whole ton of tooth structure because it's brown. It's not logical. Yeah, arrested decay, active decay. I mean, you can't look with the microscope, you can't look with anything and make the distinction. But where I see this being highly applicable is when you have to do a crown or an inlay-onlay on a tooth.
Yes.
Right?
Here, what you see here, okay, is that you have a level of infection, meaning you have to clean that up as well.
Right. Right. Okay. All right. So, hello.
Yes.
Here, so this is
okay. This clearly here is the resin in a proximal cavity, and you clearly see the infection in this area. You will not remove all this part because it is just discolored. Okay, this discoloration has other reasons, which is collagen cross-linking due to advanced glycation end product, something different. So you will not remove this. So reveal will tell you what you have to remove and what you do not have to remove. Right. It will tell you here is active decay and here is inactive decay. So
the picture in B, does that suggest that, like most resins, they just become catch-all basins for bacteria?
Yes.
Like, instead of this highly polished surface that looks great and it's white, it really isn't. It's just soaked in bacteria.
Yes, it is. So you have this, you know, that the oral biofilm generates leases of the resin, and you clearly see the penetration of the bacteria into the resin.
Okay. So here's the question. If you place resins, and we'll show it in a minute, I guess, but if you're using resins, which I mean, it would be nice if we were still using gold. I mean, I know it's not aesthetic, but probably the most effective dental restorative material. So do you use this to monitor? Is it, instead of just taking x-rays, oh, you took a bite wing, you're fine, goodbye. Yes. So, but no, that's not the way to do it.
I would call it like this. I want to understand, number one, do I have an active or an inactive decay? Okay. That's all I want to understand. Then I want to understand if my dentin is infected or just affected. And that's all. The differentiation, I will remove the active part, I will remove the infected. I will leave the affected. Using bioactive materials, I will turn into minimal invasive dentistry, and I will keep that material. Like when you have a broken nail on your finger, you do not remove the whole arm or the entire hand because you just had a broken infected nail. That's the same. So you go to the nail salon and they put on one of these long things. So that's okay too. Yeah. But you say now, what? And you say now, goodbye, GV Black, rest in peace, and thank you very much.
Okay. So here's like, none of this related to endo, but let's talk endo for a minute, because you're a prosthodontist and an endodontist as well. I mean, that's how we met, roots.
Yes.
So here's the thing. Minimally invasive endodontic access. That's wonderful. It's effective. It doesn't remove too much tooth structure. But the risk factor is if you're not removing the entire restoration to start with, which many are not doing, what are the odds that if you're not, I know microscopes and whatnot, but what if you're not using this to look at what's left when you do your little pinhole, operative or restorative driven or whatever it is? What are you missing? What's the possibility of missing that in a minimally invasive section?
You are missing exactly the infection. So the active bacteria, you're missing active bacteria, or you oversee active bacteria in the structure.
Okay, so before you actually go into the orifice of the canal system, I'm not dismissing minimally invasive. I think it makes, obviously it's the way to go. and increasingly so, especially with GentleWave. But a lot of people are not removing. They love this truss, and a lot of people are not removing the restoration. I would imagine if they saw this in a minimally invasive access, I think it would be very startling. No?
Yes. I call it like this. What is the biggest enemy of us dentists? The answer is bacteria.
Sure.
So if we do not see our enemy, imagine the war now where it is. If you do not see your enemy, if you do not identify your enemy, how can you defend?
Yeah. Well, that's been the argument with endo, is they say, well, we can, manipulate a scaler underneath the truss or underneath the restoration. Like it's okay. I don't want to belabor the point, but it seems to me that if you dismiss something without actually diagnosing it properly, diagnosis would be just a logical way to do this before you pull in your microscope and start instrumenting. So I'm sorry, I didn't mean to interrupt you. We are moving on to.
So basically, you clearly see here. This is Professor Höftasser, University Montpellier. He is among the founders of these minimal invasives concepts. You see, he is also behind the development of the so-called Sopro Live. I used all these cameras myself for a lot of time. You see it here on his working table, but you clearly see that he's now using also Reveal, because it is difficult to interrupt the treatment, to have to put the instruments aside and then take a camera and look with the camera. So now you can do everything with just one approach. This is the goal of this technology.
The question for you though, I saw Reveal at the meeting and I put the glasses on. It's the light. So it's not like you're wearing something monstrous. It's the same thing. There's no additional weight.
It's basically the problem we have to understand, the classic magnification system has received just the light, and there are layers of coatings on the surface of the glasses and of the magnification to allow you to see only what you are looking for.
Right.
Okay, so you cannot say, oh, but then I can only use the light and with my old glasses. No, you have to adjust to the new technology, because you have these coatings. So you have the blue light is exciting the bacteria. The bacteria emits lights back, but you want to see only that light. You want to see only that bacteria. So you need filters. It's called bandpass. High bandpass on the glasses, and like this you see only what you need to see.
Right. I jumped ahead at the beginning about tumor evaluation using Reveal, but we will get to it at the end. If you chose not to do this on any level, then from a standpoint of its value, tumor identification in the mouth, oral cancer, is an imperative, and we will address it before we go. I apologize, we should have done it at the beginning. Yes. Now, this, I take it, is ortho, correct?
Yes. And I call it like this. Sorry to say it. Please use Reveal in any ortho case for monitoring the case and when you remove the brackets. Clearly, you see your left resin. This is left resin after removal. Clearly, you see around the brackets, you see the bacterial contamination. The redness here proves you that there is not only a demineralization, but there is also a contamination. So clearly, and you see here, this is more brownish, meaning you have only demineralization, but here you have some orange in addition, meaning you have also some infection. So clearly, it is in every orthodontic practice a need and a responsibility towards your patient.
So somebody will come back at you and say, well, who uses brackets anymore? It's all Invisalign, right? Or whatever, aligners. So you're wearing them 22 hours a day. I would have to assume that if you're an adolescent, I guess, like say you're in your teens, the hygiene is not what it should be. So
Yes.
is this valuable during the course of the Invisalign therapy, which is,
Yes.
18, 24 months, right?
Yes. Again, it is about accumulation of bacteria beneath this the Invisalign.
Okay. All right. So we're looking at, is this more ortho coming up? I
Yes,
forget.
this is a further ortho case. Okay, you clearly see here. This is a non-active. Basically, you just left resin behind. Okay, that's all you have. It was not adequately removed, controlled, and so on. And here is a demineralization, which you have, but non-active. So you clearly don't need to address it any further.
Sure. Okay. So let's start. What generation reveal is this?
This is a sixth generation of Reveal. Just now, Designs for Vision has changed from vertical placement of the. This is my prototype, okay, from vertical into horizontal to make it easier for the clinician.
So the most important question of all is, when did you play with your grandchildren?
Yes, this is a very good question. I am very glad that I am now in the United States. I'm originally from Germany, as you know, and I am here since the birth of my second grandson. And Mr. COVID knocked at the door, and I had to decide, will I enjoy my grandchildren or not? So I decided to close back down my practice in Germany and be here in the United States with them. And I am delighted every evening they are in my bed and we read together. And yes, that's all.
Perfect life. So, but before we move on, your daughter is a very impressive lady.
Yes.
Some heavy duty publications, right?
Yes. She is a food lawyer, environmental law. She's a PhD in food law and LLM from Vermont Law School. And yes, I think she has created some value for humankind and for this planet. Her name is Gabriela Steyer, and yes, I'm extremely proud. And yes, that's all I have. Yes, I cannot.
So the acorn did not fall far from the tree, as it were, right? I remember you showing me talking about the book. I remember seeing it. Awesome. So this is an example of Pitt and Fisher issues, correct?
Yes. Yes. So basically, here you will do what? You understand that you have bacterial infection. Will you have to open all this, drill and fill? I would say bye-bye drill and fill. Here you simply you use your air abrasion, bioactive air abrasion, and then you clearly see bioactive material using air abrasion, and you clearly see when you are done. You can leave behind this brownish discoloration because this is not what you want to remove, and then you are done.
So at this level, I don't know what hygienists in the United States are allowed to do. Here they're restorative. They can do restorative work. So they could use air abrasion. So before you put Pitt and Fisher sealants on, it's almost an imperative, right? You don't want bacteria growing under the sealant.
Yes.
So from a standpoint of safety and efficacy, this would be invaluable for Pitt and Fisher. Okay.
Yes. Yes, definitive yes. Well, I have a problem like you all. I used for decades myself caries detector. There is a problem with this caries detector. You see it here. This is wisdom tooth, and it unlocks you an information. What is the information? Do I have to remove all these and you or go even deeper? Because the caries detector tells me that no, you do not. Why? You have here the dentinal tubuli. Do not forget the caries detector is a liquid. It will penetrate into the dentinal tubuli and it will create a wrong information. So basically, you just have to understand that only the area you having this redness, red fluorescence here needs to be removed. This here is cross-linked collagen from the Maillard reaction, so from advanced glycation end products, and you will not have to remove. You can leave it because it still has minerals in it, and using bioactive material, it can turn into tertiary dentin, and you can preserve it, and you don't have to do a root canal on that.
So what you're basically saying is buying a Diagnodent is not really a good thing. You don't need a Diagnodent.
I use Diagnodent myself for decades, but no, I think we now managed to go for the next step, and science proves me right.
Okay, fantastic.
Yes, so this is, I have to admit, this is still with the prototypes, with the first and second generation reveal picture, so you will not have this green image anymore. But here you clearly see here the presence of pathogenic bacteria. You understand this is an inactive problem, and this is an active problem because you clearly have the pathogens, you clearly have mutants. Here you clearly see that you need to clean before you start your anything. So before you start any treatment, you have to do an adequate disinfection of the oral cavity. I am very disappointed, and I have to mention it, to see all these superb in all these advanced presentations where guided surgery, and yes, I used guided surgery for decades myself, but you cannot do, if you have in the antagonist jaw, if you still have bacteria, you will it's gone. Okay.
So what's interesting here is that, you start eliminating the decay, air abrasion, whatever you're doing, doesn't matter, with a burr the traditional way. But at least this tells you that you're okay, you can stop.
Yes.
Right? You're done.
Yes.
Okay, so
and here you yes, this is the new generation, and you clearly
this is the latest.
Sorry?
This is the latest?
Yes.
Okay.
Okay, you clearly see here presence of bacteria. You clearly see here where you would address and you would think that you have to remove, you would not have to touch. You just have to remove this, okay, and then you are done. You can leave this brownish discoloration here, okay, because it is just cross-linked collagen. So you can leave it. Your work is number one, safetier, secured, and it is much easier. It is an easier job because you are reducing your risks and you are reducing your time.
Right.
Okay. And if you give the patient a mirror in his hand, he can see what you are doing because he has the protection glasses on, and you don't have to do blah blah. You simply share what you do and the patient will understand, and you don't need to explain everything.
So just interesting. I mean, I know we're talking about cardiology, but if you look at insurance statistics in North America, 75% of the insurance coverage is based on typical multi-surface composite restorations. It's not on implants. What I find interesting here is, I just lost my train of thought. Hold on. Oh, Style Italiano. All right.
Yes.
The biggest group in the world, like 300,000 people or something. And they're not talking about implants. They're talking about restorative dentistry. It kind of drives the point home. Yes. So given what they do, there's like 300,000 people that would benefit from this.
Those people will not benefit only they will benefit in multiple ways. Number one, the biggest benefit, as you just mentioned, endo, and I am an endodontist myself, and I taught endo. And the problem is, how do you know your irrigation, your chemical disinfection protocol was successful? This was always a problem.
Sure.
How do I know when am I done? Just because I look at the watch and I know what materials I'm using? No, not really. But now you can finish. You can do your chemical disinfection, and using reveal and additional, which let's not be too extensive here. Using reveal and additional technology, you will be able to identify: did I manage to disinfect the root canal, yes or no?
So you mentioned endo. So if you put style Italiano and style Italio endodontics together, that's 400,000 dentists around the world.
Yes,
So if they all bought one, you'd have terrific royalties and your grandchildren would never have to worry. Fantastic. Okay.
Thank you. Thank you
Okay,
very
so
much.
let's
Yeah.
take a peek. The next one is?
Yes. So again, you see here contamination, clearly contamination, which you have to deal with, and you understand the difference. You will think now, oh, this is just brownish, I don't have to touch. Yes, but you see the contamination, so you understand what you have to do and what you have to remove. It is understanding. So seeing my enemy. I want to see my enemy. That's all.
So interesting, because with things like Emax and particularly Cerac, which are used for inlay onlays, I would almost imagine that if I was using lithium disilicate or zirconia inlay onlays or whatever, this is essential, right?
Yes.
Okay.
After you will see that the resin margins, after 1.5 years, we can see already the cementation, the cement will start already with his lysis process due to oral biofilm.
Okay. The next one is,
so
there
here
we
is,
go.
yes, clearly, and this is the classic picture, okay? You would say, oh, I have to address everything. No, you do not. You clearly see the proximal. So you don't need, number one, this is to replace your X-ray because you clearly see what you have to do. Number two, here you think, oh, I have to remove all this. No, you do not have to remove this because this is clearly not contaminated and you do not have pathogenic bacteria. So clearly this is just a demineralization, and you have your collagen cross-linking and so on. So you clearly see what is needed and what is not needed. You see your enemy.
So curiosity, elderly individuals such as myself who start running into actinomycotic infection. So if I was treating a lot of patients in their 60s, 70s, 80s, this is almost essential given that most of what they're getting is root
canal. Absolutely, for the entire oral cavity. Yes. The moment the patient opens the mouth, I don't know if you are aware of, but with the pandemic, 40% of those who died in the ICU, they did not die by the virus. They died by so-called VAP, so ventilator-associated pneumonia, which was caused by the pushing down the oral microbiome into the body. Now, in the ICU, in every ICU, if there would have been someone who had used Reveal prior to intubation, identify if there is oral microbiome, pathogenic oral microbiome, we could have saved a lot of lives in this pandemic.
Okay. The next one shows.
This is a resin. This clearly here is a resin, and this resin is dissociation, and you clearly see the bacterial contamination all around the resin, so you have to remove the entire resin.
So essentially what we would look at is nothing, perhaps, because just a little black dot, no big deal.
Yes.
So any restorative procedure, any endodontic procedure, the benefit is unimpeachable.
Yes.
It just is what it is. You know, it's just a pair of loops, quick exam, the stuff is highlighted, go to work.
That's it.
All right.
Yes.
Aha.
This is now perio, and this is basically the this is clearly, this is oral hygienist. Imagine you have your oral hygienist in your office. She will not need the entire Reveal. She can have it without the magnification, just the glasses with the fluorescence and the daylight. And like this, the patient has a mirror in his hand. He will understand that this is what it is. This has to be removed. And you understand the moment when you are done with the treatment. And guess what? You clearly see here you see this is the inflammation. You clearly see the inflammation process in the gums, and you understand that you may have to do even more than just clean here for this patient.
Yeah. But the fun picture is the next one.
Yes.
Hello.
Yes. This is a picture which I used for my patients, and instead of starting to talk and to explain and to educate the patient will ask me, what is this?
Mm-hmm.
Okay, it is I call it fluorescence guided communication.
So you said that if there are glasses that only have the light attachment, right?
Yes.
Yeah, I don't want to promote designs for vision, but they're the only ones that make this. But they do have, there's no loops. It's just a basic
Yes.
pair of glasses. Okay.
It's a with filters.
Interesting.
Yes. So with filters.
Okay.
Okay. Here we are in prosthodontics. And the patient will say, well, my crown is good. Why should I replace it? Everything is fine here. Number one, you see the inflammation of the gum. Number two, you see the presence of bacteria, of biofilm, meaning this is infected and the resin beneath already, or the cement beneath is destroyed, and you have to address.
Okay. So now we're getting into the fun stuff. Like not
Yes.
that this is fun.
Well, I think that we have, number one, to understand, you clearly see this is a crack which is not contaminated, and this is a crack which is contaminated. And here now we hope in the future to be able to change the way to address this area. Yes, Anil Kishan's ideas with his which I love very much and I appreciate very much, and I'm grateful for what he has done and this continues to do. This is where it will be usable and so on. But you have to see and you have to understand what you do. So without seeing, you don't know what to do.
So you're talking about Anil Kish, they're re-wetting dentin and getting remineralization. Is that correct?
Well, they have also they are using this nanotechnology for disinfection as well. Meaning, what is very important is the so-called targeted drug delivery. What does this mean? This means that the disinfectant can be targeted exactly to where you need it, exactly in this area. Okay, you use nanorobots, and with these nanorobots you address exactly the disinfection of this area. Using Reveal now, and for example, a dead life assay, you will be able to identify and see, did I manage to disinfect? Yes or no? Am I ready? Can I go for the restoration?
It's interesting because Anil has been doing this for years, but I think,
yes.
What's his name? Bruder and Cutler. I think they're all together, and they're actually bringing out sealants and root end amalgams and like root end retro sealing material. So
yes.
it's on the market, and
yes.
this nanotech, the chitosan nanotech nanoparticle is actually very much available in terms of being able to use for.
But you need to see it. You need to see it. You need to see it.
Right.
So this is exactly where the two ideas merge together.
Fantastic. So let's get really ugly. And the next one I think is implants, right?
Yes.
Yes.
Basically, you clearly see, again, you see what you see. I do not have to explain anymore. You see the inflammation, and you clearly see that this crown, this is a screwed in crown on an implant. You clearly see that there was an unscrewing in the so you have to refasten that, but you have to take it off and to disinfect. And you clearly see the penetration of the bacteria into beneath the ceramic on the construction.
Okay.
And if you want to see that, this is the bed case.
This is it.
Yes, this is the bad case. I have to be grateful. These are pictures from my friend and colleague, Dr. Gal Hilch, from Israel. He is my friend and colleague, and we work very intensively together. He is also, I supervise his PhD as well. And you clearly see a case out of the practice. He's from the beginning a user of Reveal, and you clearly see what's going on. And you have used Reveal continuously, you wouldn't have allowed this to happen. You would have known when you are finished with disinfection and cleaning, and the patient would have understood as well much better what's going on. So it is also for communication, motivation, treatment acceptance, as well as why bring the patient back in the practice on a regular basis, what you have to do, and so on. It's a different way of communication, of treatment. It's a completely new concept.
Right. So the $64,000 question, which is with inflation is now worth about $2.5 million, is if you're doing the implants, are you not better off when you do the osteotomy and you do the placement to be wearing Reveal?
Yes, you have. Because today, what you are doing today, mostly we try to do this so-called immediate implant placement. You very nicely remove, or if you are using the shield technology, you leave behind something. But how do you know what you left behind?
Right.
The idea is, I want to see my enemy. And bacteria is my enemy. Like yourself, I was not the very best in microbiology in my grad school, but now today I understand what bacteria is.
It's interesting.
I can see it.
I started to work with Dirk Dudek, who you may know, the Clean Implant Foundation. And
yes, I know it very well.
You know him? He
very
picks
well.
up the contaminants on the surface of supposedly sterile SLA, whatever, implants. And the contaminants vary significantly. Sulfur, the DBA, I think it is, various plastics from the packaging. And people say, I have a sterilized implant, no problem, put it in. But between what's residual and the contaminants on the implant, suddenly peri-implantitis begins to mean something, right? It
Absolutely.
It's the etiology of it begins to make much, much more sense. It's not just insufficient tissue or insufficient bone. It's the contamination, both of the osteotomy and of the medical device, which complicates matters.
You may be familiar when someone goes to an optometrist and he receives lenses, they have this sodium fluorescein. You and me, we remember early days sodium fluorescein. We were using it for to identify hidden canals. You remember?
Yep.
So this is something
of the ophthalmic solutions, right?
Exactly. Yeah. But you can use sodium fluorescein to identify contamination of the surface. You just take one of those strips and you put it on the surface with a little bit of water, and then you take Reveal and you suddenly see if it is a contamination on the surface or not.
So before we go on, I have to recall, let me think how this went. You were the advocate of, after root canal therapy, using salicylates, right?
Yes.
So everybody kind of went, but you know what? But you were right. And this is 20 years ago, right?
Yes.
The destruction, the denaturation of the dentin,
after
being bathed in sodium hypochlorite for an hour or more, the salicylates actually made a difference in terms of the ability for the material.
I am also today the advocate, and we will publish soon again on the topic. You may remember that I was an advocate of hypochlorous acid.
Yes, yes.
Okay, so sodium hypochlorite, the still so-called golden standard, irrigation, and we endodontists used it not only at a low concentration, you used it up to 5%, and we heated it up. Okay, this destroys the dentin. And we have the documentation and the data showing that sodium hypochlorite destroys dentin, while hypochlorous acid is quite the very same, just it is not destructive. And if you want, you can simply drink hypochlorous acid. You remember Sterilox those days?
Sterilox, right.
You remember? So basically it was, we did the mistake, and we continue to do the mistake to use sodium hypochlorite, which is really destroying the dentin as it is.
Interesting. Sterilox was Ultradent, and everybody, Gary Carr and the boys were using it off label, right? If I remember
Yes,
correctly.
exactly. But today we use Dentaqua, also Dentaqua, and we use there a very higher concentration than we used. You remember we were talking about Sterilox, and we run the solution twice to have a higher concentration.
Right,
remember?
right.
So this is what we do today. We have already a machine, a technology available to use it for the disinfection.
Was John McSpadden, who unfortunately passed away way too early. He was working at the Oak Ridges laboratories. He was coming up with a solution that you literally could drink, but the disinfectant, is that what you're talking about?
Yes, because hypochlorous acid is produced by the body in the infection.
Okay.
It's basically water and salt, and you put it in the electrolysis. That's all. It's what you can drink. There is nothing special.
Okay.
So it's water and salt, and you can use you run it through the electrolysis, and you have different concentrations of or different amounts of salt which you add, and you then have what you have the disinfectant. And it is FDA approved, hypochlorous acid. You don't need to expect anything. It is the disinfection material per se. All this alcoholic hand disinfection, forget it.
Yeah. It's sad. John McSpadden, like I say, died way too young. I remember visiting him in Chattanooga or Lookout Mountain or whatever it was. It was like going to the Mahatma, it was like going to the top of the mountain to hear from it's sad. He was a young man.
Yes.
So where are we next? Where is...
Yes. So basically further implants, and it doesn't matter their name, it doesn't the manufacturer, it doesn't matter the surface. You will have the very same with almost everyone if you do not adequately address it. Yes, basically that was my presentation.
Okay, but it's not your presentation, because I want to go back for a minute. And I won't mention any names, but the devices that are being used for oral cancer screening by dentists.
Yes.
So briefly, oral cancer is considered to be 10% of the cancers that occur, right? Something like that?
Yes.
Higher incidence in countries that use betel nuts and smoke like crazy and drink like crazy. There has been restrictions on smoking in adolescents, I think, in Australia, right? You're saying? Okay.
Yes.
So, but oral cancer screening is obviously necessary, all right? But the stuff that's on the market is, with all due respect, not really diagnostic. It's also a lot of false positives. However, Reveal changes that, correctly?
Yes.
Am I right?
Yes. I will explain where I'm coming from. Today, fluorescence guided surgery is a recognized and in place technology. What does this mean? When tumor surgeons have to remove the tumor, what is their problem? Their problem is to see the margins of the tumor. Otherwise, they cut too much or they cut not enough. If they do not cut enough, they have to do a second surgery. If they cut too much, they left the patient with the problems. Now, using fluorescence guided surgery allows you to go that precisely that you almost do not need pathology. Neurosurgeons, well, you understand they are working here, okay? They speak to God, not us, but they speak to God, what they leave behind or not. So neurosurgeons today are using so-called fluorescence guided surgery.
Okay.
They started using it together using microscopes. Today they are using Reveal because it is much easier and much more precise as they published and researched. Now, they use it in combination with a photosensitizer. what is this photosensitizer? You might remember at the beginning we spoke about in blood, when blood is in the body, when we generate blood, we have this so-called protoporphyrin 9. So this protoporphyrin 9 you can buy it over the counter. Okay, one should use it for his health as well. So it's called 5-ALA. The patient receives this 5-ALA systemically. There is an incubation time, and then the fluorescence guided, the neurosurgeon will know exactly using fluorescence guided surgery what to remove. But instead of only using systemically, you can use it topical. You may remember when you speak to your wife, she will tell you, yes, I know what microneedle is, because when I'm going to cosmetics, the cosmetologists are using microneedling.
Yeah.
Okay. And for example, Cleopatra, Chris Necropolis, she was just advertising. She was just advertising the Dermapen, which is also microneedling. So use a microneedling technology and 5-ALA when you clearly see that that you have a lesion on the tissue, and then you go simply and apply with microneedling the 5-ALA, use reveal, and you'll understand, do I have to immediately refer the patient at a highest speed to surgery, yes or no? But this is the way to indeed do, it's called photodynamic early cancer screening.
Interesting, because there's a fellow on that publishes on BEIDE NEXUS. He's from Romania, Georgita Mirsu. So he's kind of like, he's an oral maxillofacial surgeon, but you always see him doing dissections and, you know, massive jaw resections, and he uses these fantastic 3D printed, almost like Lincal, frames with implants coming up.
Yes.
He's the extreme example, but obviously this is relevant.
Yes.
But any oral surgeon, in addition to soft tissue, any oral surgeon who's taking out an ameloblastoma, who's dealing with bisphosphate-generated osteonecrosis, the applications are myriad, because, like you say, you can't treat what you don't see, and this just adds another vision factor. So this was a lot of fun. The only problem is that I can't smoke a cigar. You can't give me one of your cigars.
Yes.
Are they still Cuban?
As you remember very well, no, I do not. I'm long away.
You stopped smoking cigars.
Oh, yeah, everything.
The world has changed. Okay.
You know, I see now, if you see it, you understand it. Your brain, your understanding, okay? I can only accept what I see. If I see, then I understand. And this is where I am.
Well, it's not just reveal, but I can't really say what it is, as you've told me, so I won't disclose it. But you've got what, 3 more patents related to this sort of thing coming up?
Yes, we will have several. Yes, we just started a big randomized clinical control trial as a proof of concept for. I have to say, 40% of all radio and chemotherapy patients have oral mucositis, and they do not die of their cancer. Okay, if you speak to an oncologist, he will tell you they are concerned about oral mucositis, but they do not care, because they say we have antibiotics and corticosteroids. But that's all. And we are trying to prove that you don't need corticosteroids and antibiotics to treat and to prevent oral mucositis.
Well, it goes back even further than that. There were a lot of studies done in the VA years ago. They would do, veterans that had arms removed. They had to do hip and knee replacements. They were failing. And why were they failing? They found oral microbiota on the failed part of the implant that was replaced in the hip and the knee.
And you go to the dermatologist, he checks your skin. Okay. I hope you never trust him if he looks with his eyes. there is science to prove that fluorescence is needed to identify and to diagnose skin.
Amazing.
Wound care, in the war now, to understand when they got rid in those injured patients of the infection, they should use fluorescence. Okay, so you understand where this goes.
It's
like flowers and plants without light cannot exist. Okay. We humans without light cannot exist.
Well, we've come a long way from roots, my friend. This is like a long, long way. And I really appreciate you doing this. I know it's a long session, but I certainly hope people understand it and take the time to do it. And hopefully the people at Cell Reveal will kind of, instead of, you know what I'm saying, right? I know they're commercial, the science, whatever, but if you distill this down, there's a very relevant reason for doing this. Yes. So I'm going to say goodbye. I really enjoyed you doing this, Levu. As I say, it's you were always overwhelming. Your brain was always in the cosmos somewhere. It's fantastic. So I'm going to say goodbye. Hopefully, next time I'm in Boston, you're in Boston, right? Next time I'm in Boston, which I haven't been in too long a time, come visit. Okay.
Please.
Be my pleasure. Take care of yourself and keep on keeping on, my friend. Okay.
Thank you very much.
Right, take care. Bye-bye. Bye.
Bye. Bye.